Hello, good afternoon, everybody. Today we'll be talking about a very important topic and a very neglected topic is regarding male infertility. First of all, I would like to reiterate here that it's usually the males who don't think that they have a problem. And in this male dominated society, often women also think that males may not have a problem. So we have to burst this myth and see what's the fact are. Usually it's the males which say that I keep my problems, my struggles, my mistakes to myself because in reality no one really cares. But I think so that for males we should start caring, we should allow them to speak. There is no go-to person for a man. For women or for daughters, it's their mothers who are their go-to persons. But for sons, they usually don't react with their mothers. They usually don't react with their fathers, and they keep all their secrets. They keep all their problems with themselves many of times. And this takes place in the male fertility as well. So we want to break this thing. So today we are going to talk about A to Z of male fertility. And if we see, we start from the analysis of semen and expansion of this male infertility treatment has gone exponentially high. And we have the options of choosing a very good sperm for fertility. That is the Z for zeta potential. So we are going to talk about each one of these. So if we see about the male factor contribution to infertility, what is infertility basically is that if a couple is trying to conceive and they are not able to conceive after 1 year of regular intercourse in a woman aged less than 35 or 6 months of regular intercourse without use of contraception in a woman aged more than 35 years. Why the age of woman is important? Because the fertility drops after 35 years. We are going to talk about the importance of age in a man also. So if we consider this as infertile cases, 30% of the infertility is due to female factor, 30%, which is a huge chunk, is due to male factor infertility. 20% are mixed, that's male and female combined, and 20%, 10 to 20% can be unexplained infertility cases. So if we see the causes of male infertility, 34% of them are due to unexplained causes. Other more important ones are the presence of varicocele or tortuosity around the testis, undescended testis, infection, sexual behavior, sexual factors, immune-related causes, pre-testicular, testicular, and post-testicular causes. We'll go into the details of it, but we'll see that why is infertility rising. So it's this lifestyle change, it's the change in the atmosphere around us, as well as the man is evolving, there is a late age of marriage. All these factors are contributing to infertility. In male infertility, we can see that there is an increased risk of obesity these days, a poor diet, exposure to environmental toxins. All this has led to a rise in male infertility as well. And that's why we are going to discuss today's topic. Age factor, if we consider the testosterone levels in a man, they are usually not affected more so till 40 years of age. As a man crosses age 50, at around age 55, the testosterone levels drop to more than 50% of their original value. And this leads to male factor infertility after that age. But there can be premature, like a normal age man can also have infertile problems. But the fertility of a man will usually be preserved till around 40 to 50 years of age. Now we are going to talk something about physiology. What's normal in a man? So usually brain is an organ which will induce or start secreting some hormones. And the area of the brain which secretes these hormones is called as the hypothalamus and pituitary. There is something called as the hypothalamo-pituitary gonadal axis. And this axis has to be normal for all the fertility functions to be there in place for man. Hypothalamus secretes some releasing hormones like the gonadotropin releasing hormone, the GnRH. which will act on the pituitary to release the gonadotrophins in the form of FSH and LH. This FSH and LH will later on act on the testis, and then testis will start producing the male hormone, which is the testosterone, which is secreted by the action of LH, and the FSH acting on the testis will induce the Sertoli cells present in the testis to secrete sperms. So actions of both these hormones is very, very necessary for smooth functioning of a male reproductive system. The male secondary sexual characters like appearance of hoarse voice, mustache, beard, all this will take place under the effect of testosterone getting converted to its active molecule called as the dihydrotestosterone. So this is the normal physiology in a man. Now we'll see what's the problem, what problems can occur and where the problems can occur. So man can have problems coming before the testicular level, like the testis is where the sperms are produced, but before that, the hypothalamo-pituitary gonadal axis, which we talked about. So if the hormones which are secreted from the brain are in a lower level, if there are certain problems in the axis, if there are certain problems like Klinefelter syndrome, presence of an X chromosome in a man, secondary hypogonadism, Kallman syndrome, all this will cause hormonal disturbances, and this is called as a hypogonadotrophic hypogonadism, which comes into the pretesticular causes of male infertility. Then we have something called as the testicular causes. So the testis is not functioning well. So this can occur due to undescended testis, some infections, some chromosomal problems, some genital tract trauma. All this can lead to an improperly or inadequately functioning testis. And if the testis is inadequately functioning, the sperms will be produced in a very less quantity. Testosterone will be also produced in a very less quantity. Since the testosterone levels are less, the brain tries to increase the FSH and LH levels, and the FSH and LH levels can be very, very high. So this is called as a hypergonadotrophic hypogonadism. Then we have something called as a post-testicular causes, where there is a problem beyond the level of testis. Like the testis is producing sperms nicely, the brain is also functioning very nicely, but the sperms are not able to come outside. So this transportation pathway from the testis to the external environment is disturbed. Then it is classified as post-testicular causes. So we'll see each one of these. What are the pre-testicular causes? So if there is a problem in the hypothalamic level, we call this as a hypogonadotrophic hypogonadism, where in Kallman syndrome, CHH, we can have disturbances. We can have pituitary level problems like isolated LH or FSH deficiency, some tumors of the pituitary, trauma to the brain, critical chronic diseases. All these come into pretesticular causes. Also, there can be disturbances in the sexual function like erectile and ejaculatory dysfunction. This can also be classified into the pretesticular causes. Testicular causes, if we see, they are basically the largest cause is the presence of varicocele, where the tortuosity of the veins present around the testis. This leads to a rise in the temperature of the testis, and because of this, the sperm production will be at defect. The count, the motility, and the morphology all will have an impact on this. Another cause of testicular disturbance is cryptorchidism, where the testis fails to descend to their normal position. They can be caught in the pelvis, they can be caught in the inguinal canal or somewhere up, and this can cause problems in the sperm development. Then there are certain chromosomal disorders like Noonan syndrome, presence of X chromosome in a man, presence of XYY chromosome, Klinefelter syndrome. All these can lead to testicular problems. Chronic diseases like the liver and kidney disorders, immune-related disorders, which can cause inflammatory problems in the testis, can also cause a disturbance in the testicular function. Then there can be torsion of testis or trauma directly to the testis. There can be some toxins like the exposure to radiation, chemotoxins, drugs can also cause problems. There can be some blood-related disorders like sickle cell disease, beta thalassemia, which can also cause problems in the testicular function. After all this, if all this is functioning nicely, then there can be problem at a post-testicular level. So then testis is okay, it's producing sperms very nicely, but the sperms are not able to come outside. This can be a congenital cause in the form of congenital absence of vas deferens, or Other ducts can be blocked, most common reason in India being infections. These infections can be sexually transmitted infections, or the most common infection which causes infertility in India is tuberculosis. So all this can cause problems at the post-testicular levels. Some cases can be due to iatrogenic, like some operations can predispose to damage to the vas deferens. Then we have obstruction of vas deferens due to vasectomy, which is a surgery done for preventing pregnancy, and this surgery is called as a male sterilization. So this can also cause problems at the post-testicular level. So how do we manage male infertility? So for management of male infertility, we need to find out the cause first. And for it, we need to take a thorough history of a person, of a man. We need to examine a man. We need to see the external genitalia, the presence or absence of secondary sexual characters. Are there any problems in this? Then comes the investigation, out of which the semen analysis is the first and foremost investigation. After that, we come to different types of investigations. Once we are through with the cause for male infertility, we come to the treatment. Treatment can be in the form of medicines, it can be in the form of surgery, or it can be artificial reproductive technologies like IUI or IVF. So we are going to talk about each one of these. So physical examination will tell us if there is any problem with the male external genitalia, if there is a problem in the size of testis, if there is a problem in the presence or absence of vas deferens, is it a non-obstructive azoospermia or obstructive azoospermia at the first go? Are there any markers of hormonal imbalance? Are there any factors of genetic disturbances like Noonan syndrome? All these will have typical physical features. Then we come to the first and foremost investigation, which is the semen analysis. Instructions should be nicely given to a patient before he produces semen. So abstinence period of around 2 to 7 days is very, very necessary before a semen is produced. And a single semen analysis may not give you a clue. So at least 2 semen analysis to conclude whether the problem is actual or not is very, very necessary. And these 2 semen analysis should be around 1 month apart. The total absence of sperm is called as azoospermia. If there are very few sperms after centrifugation, we call this as cryptozoospermia. If the sperm count is decreased less than 15 million per ml, we call this as oligozoospermia. And if everything is normal, then we call it as normozoospermia. So if the semen count is showing a decrease, if there is a decrease in motility, what all factors we need to see before we label it as a case of oligospermia? This is very important. So I told you, not a single semen analysis should be sufficient. We should repeat a semen analysis after giving proper medication after 1 month. So the abstinence duration is very important. It should be between 2 to 7 days, not less than 2 days and not more than 7 days. We should ask for a history of spillage while collecting semen. So if there is a history of spillage while collecting semen, there can be a problem. Then the pH of semen, volume of the ejaculate can be very, very important. The viscosity of or the stickiness of the semen is also very important. Presence or absence of infection can also lead to decrease or increase of the sperm count. Now, what all other tests we can do? So if there is a problem in the semen, if there is a very low semen count, we can order some hormones. And when are these hormones ordered? Whenever the sperm count drops below 10 million, if there is low volume testis or persistently low volume ejaculate, or if there is a sexual dysfunction, in all these cases we test for male hormones. Which are these hormones? We check for serum levels of follicle stimulating hormone, LH hormone, thyroid stimulating hormone, prolactin, and the male hormone testosterone. Estrogen levels can also be done in a man. The testosterone to estradiol ratio can also sometimes guide us regarding the further line of management. So these are the hormonal tests which we do, and different hormonal tests which will tell us whether the cause is a pre-testicular, testicular, or a post-testicular problem in that man. While doing semen examination, if the semen volume is persistently low, but the patient is experiencing ejaculation, in that case, we need to rule out what is called as post-retrograde ejaculation, where the ejaculate goes into the urinary bladder. And for this, we need to examine the urine after the sexual activity or after masturbation. So this post-ejaculatory urine sample is examined for presence or absence of sperms. And if sperms are present in the urine, This indicates that there is a presence of retrograde ejaculation. In some patients where the count is persistently low and examination points to presence of some tortuous vessels, we can do something called as a scrotal sonography or a scrotal Doppler. This scrotal Doppler will tell us if there are dilated veins around the testis, which is called as varicocele. If we can see the varicocele, if the Doppler tells us that it is a grade 3 varicocele, we may have to go for something called as varicocele surgery, where we do the varicocelectomy and remove this tortuosity around the testis so that the temperature of the testis remains at a very good level and the sperm production, its motility and morphology are not affected. So this is one form of treatment. Sometimes, in spite of doing all things, the sperm count is normal, and in spite of that, the IUI or IVF procedures, if the patient has undergone, they are not successful. We may do a higher end test, which is called as a DNA fragmentation index. DNA fragmentation index or DFI tells us the damage to the sperm DNA which is occurring. This can be due to multiple factors. Most of the times, if the DFI is more than 30%, it indicates that there is a problem with the sperm production or transport, and we can suggest different forms of therapies for such patients. Sometimes the sperm count can be zero, and this can be very distressing to the man as well as to the family. In these patients, we have special forms of treatment. You can see the flow chart. So if the FSH levels are normal, we call this as obstructive azoospermia. The sperm count is zero, but the sperms are being produced in the testis, and they have got a very good prognosis of treatment. So we can directly remove the sperms from the epididymis, which is called as percutaneous epididymal sperm aspiration or PISA, or we can do a testicular sperm aspiration or TISA. So if this is done only if FSH levels are normal. If the FSH levels are high, that indicates that the testis is not functioning properly, and this is called as non-obstructive azoospermia or NOA. In this kind of patients, we need to do a higher end procedure for retrieval of sperms, and this is called as microsurgical testicular sperm extraction. So these are the forms of treatment. If the sperm counts are very, very low, if the sperm counts are zero, we can undertake some genetic tests to see for the cause of male infertility. These are in the form of karyotyping, Y chromosome microdeletion, or if there is an obstructive cause, we can do CFTR gene mutation. So these are the tests. What are treatment options available to man? So finding the cause and treating it specifically will help the man. So finding the cause and investigations to find the cause are very, very important. Then the next form of treatment can be intrauterine insemination for those who are having oligospermia. IVF or artificial reproductive technology can be an option for those who have severe problems in male infertility. So if the problems are complex, this is a complex flow chart, so which we have to follow. If there is a normal semen count, we can consider about female factors for infertility or a raised DFI. If there is azoospermia, we have to see if there is a non-obstructive azoospermia or obstructive azoospermia. If it is obstructive azoospermia, we have to check for CFTR gene mutation. If it is a non-obstructive azoospermia, you can check for Y chromosome microdeletion and karyotyping. So these are the steps which we take. The most important thing is lifestyle modification. If the sperm count is borderline low level, change in lifestyle is very important. To decrease the obesity is very, very important. Dietary modification, a good exercise regimen can help in this. Along with this, the sperm count can also be improved by giving antioxidants. The reactive oxygen species present in the body is bound to affect the sperms very seriously, and therefore if we are giving antioxidants, the semen count can improve. If there is any infection, we can give antibiotics. If the testosterone to estrogen ratio is reduced, in such patients we can use oral agents which will decrease the estrogen levels in the form of clomiphene citrate or letrozole. And in some cases where the brain is producing less hormones and because of that the male is having infertility, in that case we can give some injections in the form of HCG or gonadotrophins. So this is about the medical line of management. Suppose the male factor fails to improve and there is a low sperm count in the form of around 5 to 15 million of sperm. So normal sperm count is average sperm count is around 40 to 50 million. If the count drops below 15, we call it as oligospermia. And whenever the count is between 5 to 15, we call it as moderate level, mild to moderate level of oligospermia. For these kind of patients, we can do a procedure called as intrauterine insemination, where we are concentrating the sperms, we are removing the dead sperms, we are selecting the most able, most motile, most best kind of sperms by a technique called as semen washing. After doing the semen wash, we fill the sperms in a small catheter and a syringe. This is called as the IUI catheter, and then we do an intrauterine transfer of the sperms by a procedure which is called as intrauterine insemination. Intrauterine insemination has an average success rate of around 15 to 20 odd percent. So we have to do this procedure for around 3 to 4 times. Suppose you get a pregnancy, well and good, but if you fail to conceive after 4 cycles of IUI, there's no point in doing it again and again. We have to reevaluate the patient. You have to find the cause again. And if there are multiple causes or if the IUI's treatment has already failed, we have to proceed to further line of treatment in the form of artificial reproductive techniques, IVF or ICSI. IVF is where we take the egg outside of a woman, we put the sperms around it, and the sperms will go and fertilize the egg. But if the semen count is very, very abnormal, like if there is a severe oligospermia, the sperm count is less than 5 million, in those patients, we have to undertake a procedure called as ICSI or intracytoplasmic sperm injection. So for very severe male factor infertility, we have option of ICSI as well. Whenever there is obstructive azoospermia, we can undertake a procedure for removing the sperm outside the body or sperm retrieval techniques, which is called as a percutaneous epididymal sperm extraction or aspiration. This is called as PESA. If PESA doesn't help, we can undertake testicular sperm aspiration or TISA. This procedure will give you good results, but if there is a non-obstructive azoospermia and the FSH levels are very, very high, in this kind of patients, we have at IVF Fertility a very novel technique of sperm extraction in the form of microsurgical testicular sperm extraction or MTSA. This technique was introduced in early 2000, and we have expert panel of urologists and neurosurgeons which do this procedure for you, and we can get a good result. If we see that the results for TISA are just 5 to 10% for a non-obstructive azoospermia, in microsurgical sperm extraction from the testis, the results will be somewhere around 50 to 60%. So that's the extent of approval of the results. So specially reserved for very severe cases. Then there are novel techniques which we follow for sperm selection at IVF Fertility, and this sperm selection for IVF or ICSI is very, very important if there is a very severe problem. So we have IMSI, that is morphological sperm selection. Under very high magnification, we see the sperms under 6000x magnification and then select the sperms for IVF or ICSI. Then we have some special technique called as PICSI, which is physiological ICSI, where the most motile, the best sperm will travel physiologically faster, and this kind of sperms are selected for ICSI. Then we have certain techniques called as microfluidics also. This is the micro TC procedure being done. We have electrophoresis techniques for sperm selection in the form of sperm cell sorter. This is the zeta potential technique for sperm selection. We have microfluidics. So we have microfluidics chamber. So those who have a raised DNA fragmentation index, those who have problems with the motility, morphology, and the count, which is called as oligoasthenoteratospermia, these are the kind of patients which require novel techniques of sperm selection, and that's where we use microfluidics. There is something called as magnetic activated cell sorting, and this MAX technique can help us select less damaged sperms. So this is also one important novel technique which we can use, where the sperms coming in the center, which are not getting attached to the magnet, are usually the healthy sperms, and this can be used for intrauterine insemination or IVF procedures. If the male has got a genetic problem, then in that case, if we are forming our embryo, we can take an embryo biopsy and see whether the embryo doesn't have the same genetic problem which the man has. This technique is called as pre-implantation genetic testing for aneuploidy, PGTA, and similarly we have other techniques like PGT-SR and PGT-M. So all these can be used to increase our results in male factor infertility. Friends, this is what we have, but the future is expanding and we have newer and newer diagnostic tests, newer and newer therapeutic modalities which are coming on the horizon. So we are now starting to prepare artificial gametes. We can, in the animal models, man has started to prepare artificial sperms, artificial eggs, and xenotransplantation of testicular tissue. Stem cells, gene therapy are way ahead. So all these techniques will be there for future. But right now, whatever we have, I have told you. So in the end, I would like to say to all the men that believe in yourself, you were the fastest sperm. Never forget you came into this world as a winner. Thank you so much for your patient hearing. I hope I was clear in my topic on male infertility. Thank you. I would like to take the questions now. Yeah. So the first question is, how can smoking affect fertility? Since we see its effects on lungs, yeah, definitely smoking affects the count, the motility, as well as the sperm morphology. And all of these are very, very important for good male factor fertility. Smoking can specifically affect the motility part of it, and therefore, the number of cigarettes smoked per day, the number of packs of cigarettes smoked per day can tell us the severity of the affection of a man. So, smoking cessation forms a very, very important aspect of lifestyle modification in cases of male factor infertility. Can stress and lifestyle habits cause male infertility? Yeah, definitely. Stress will lead to changes in the male hormone pattern, rise in the levels of insulins, decrease in the levels of endorphins and enkephalins, and this will affect the secretion synthesis of sperms. This can affect the sexual performance as of a man as well, resulting in erectile and ejaculatory dysfunction. So stress levels and lifestyle modification is very, very necessary. If we talk about a very important lifestyle modification is to reduce weight. So obesity is a very, very important factor for male as well as female infertility. And obese man has more problems in the semen than a healthy man. So in this aspect also, a very good diet, a very good exercise regimen, and lots of fluid intake is very, very necessary for a good male factor fertility. Can we have the next question? Yeah, how is the health of semen evaluated? So, semen evaluation usually is done by World Health Organization standards. We see for the volume of sperm, the volume of semen should be around 1.5 to 3 ml. Less than that is problem. More than that can indicate infection or some other problems. The pH or the acidity or alkalinity of the semen is also very important. The viscosity of the semen sample is again very important. Presence of dead or difference with differentiating it from live sperms is also very important. That indicates the vitality of the semen. Then comes the three important factors, that is the count, the motility, and the morphology. The normal average count of semen sample is somewhere between 40 to 60 million per ml. If this count is dropping below 15 million per ml, we call this as a low sperm count or oligospermia. If this count is dropping below 5 million per ml, we call it as a severe oligospermia. If the motility is less, we call it as asthenospermia. The motility of the sperm, the rapid progressive and the slow progressive motility should be more than 32%. The morphology or the normal shaped sperms are also very important for fertility. If the shape of the sperms is abnormal and less than 4% are showing a normal forms, then that indicates that the morphology is abnormal. So all these factors taken together will indicate the health of a semen. What are the symptoms of male infertility? So it's just that there are no specific symptoms for male infertility, but of course, if there are sexual disturbance, that will be present. So there can be erectile dysfunction, there can be ejaculatory dysfunction if there are sexual problems. There can be dyspareunia in cases of phimosis, where the band of the skin over the penis is stretched during having a intercourse. So all this can cause problems. But in general, if a couple fails to conceive, that is the most important symptom of male infertility. Are there any genetic or aging issues that hurt male fertility? Does family history matter? Definitely, yes. If the problems are very severe, if it's a case of azoospermia, we definitely think of genetic causes like Kalman syndrome, X presence of X chromosome, which is 46XX man, or a presence of extra Y chromosome or a presence of extra X chromosomes can also cause problems. If there is a problem in the Y chromosome in the form of Y chromosome microdeletions, this can also affect a man. If there is a problem in the motility or there is obstructive azoospermia, in these cases we look for a genetic cause which is called as the CFTR gene mutation. So all these genetic causes can cause a problem, and this can be inherited to an extent. Regarding aging, we discussed that usually by a normal process, if we go, a man usually can produce good quality sperms and testosterone till around 50 to 55 years of age. So aging in man can be seen normally after that. Thank you. What is a common fertility treatment protocol for a man with infertility? So basically, as we said, we have to find the cause first. If we find the cause, we can specifically treat that cause and then go ahead and treat the man. If the problems are less, we can treat them by medicines, and these medicines can be in a variety of forms, which we discussed in the lecture. Then the next option is intrauterine insemination, where the sperm count is low, the motility is low, and we are going to help the sperms go nearer to the egg. So the sperms are processed by a process called as semen washing, and then they are transferred inside the uterine cavity. If the problems of fertility are severe and if IUI hasn't helped, if the medical line of management hasn't helped, in all these cases we go for artificial reproductive technologies in the form of IVF or ICSI. In this, if there is problems in giving the semen, we have sperm retrieval techniques. We talked about TISA, we talked about PISA, we talked about microsurgical TESE. All these procedures can help. Then there are something called as sperm selection techniques in very severe cases where the sperm volume is very low, the count is very low, and we want to select a very good sperm for ICSI. We have that option also. Next question. What common factors hurt male fertility? So what are the high risk factors? So there are some occupational exposures. So if a man is working in some environment where there's a very high level of temperature or heat is more, like furnaces, X-ray departments where there's an exposure to radiation. If they are using working in an atomic plant, then again the exposure to radiation is very very high. If they are working in some chemical factories where the exposure to chemicals is high, this occupational exposure will risk a man to infertility. Then we have certain infections in the form of sexually transmitted infections like chlamydia, gonorrhea, syphilis. This can also predispose to infertility. Other infections such as tuberculosis can cause problems in testicular sperm production as well as the transport of the sperms outside. Then there can be direct trauma to the testis, which can also cause problems. Some childhood infections like mumps can also predispose a man to infertility. Certain surgeries like hernia surgery, hydrocele surgery can sometimes predispose a man to fertility. These are the iatrogenic causes of infertility. And of course, the genetic causes which we talked about. So, all these are common factors which hurt male fertility. We have the next question. Can low sperm count be treated? So, Yes, definitely low sperm count can be treated. It can be treated by a lifestyle modification, which we talked about, a good diet, a good exercise plan, and plenty of liquid intake. Secondly, we talked about medical line of management in the form of tablets for some patients, in the form of injections for some patients. If this doesn't help, we have to check for any presence of varicocele or obstruction to sperms coming out. So surgical form of treatment can also help some men. So these are the lines of management how we can treat a low sperm count. We go to the next question. What can a man do to boost fertility? So I think this is the ultimate question to revise all what we have discussed till now. So we discussed about the lifestyle modification. They need to exercise. We need to keep ourselves fit. Anxiety or stress levels should be reduced so that the sexual disturbances don't arise. Once the anxiety sets in, the sexual performance can be affected in the form of erectile and ejaculatory disturbances. A good diet, a good exercise regimen, and really relieving a person of his stress and anxiety is very, very important. With that, a man can take help of a medical expert to boost his fertility. With this, I hope I am able to answer all your queries on male factor infertility. We do have specialized Andro Life clinic at Oasis Fertility. Do visit us for any of your queries on our website at oasisindia.in. Reach out to us at Oasis Fertility Pune, the Andro Life clinic for men. At Wakad, we are available. We have a toll-free number which is being displayed. You can call there, or we have Oasis Fertility Pune number which is available on Google. If you like this video, kindly share for those who need this. Thank you so much for your patient hearing. See you in next XB Live. Thank you.